all know, today we are going to discuss symptoms in palliative care. Okay. Today we will be discussing about two symptoms in detail, that is breathlessness and cough. First one, breathlessness. We know, first we can see the prevalence of breathlessness. In lung cancers, it is about 75 to 87%. We may have seen many cases presenting to us with breathlessness and most common COPD. Okay. And then advanced cancers with metastasis, for example, in breast cancer with lung mets and all, it's or any other cancer with metastasis to lungs, it can cause breathlessness. And in AIDS and heart disease, mostly associated with cardiac failure, and again renal diseases. Next. Okay. So before that, the American Thoracic Society defines dyspnea as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So, it's a subjective experience. So, we cannot judge the patient. We have to see each patient and we have to take the history, and from that we have to get an idea. Okay, next. It is one of the most distressing symptoms. We know in palliative care or in any other setting also, the patient may be presenting to us with many other symptoms like pain, uh, breathlessness, or maybe there may be edema, cellulitis, lymphedema, wound, fungating wound, or chronic ulcers, like that way. So all these are distressing symptoms. Sorry, there is a spelling error in here. Kindly excuse. So it is a distressing symptom for both patient as well as the family. Why? Because when a patient is being gasping or when a family member is being struggling to take breath, it will be very distress for the family members also or near ones to witness this. Okay, so we have to treat them with that priority. So, previous slide. Yes, it's a difficult symptom for the professionals as well to manage because when it is being presenting to us, mostly it may be in the end of life or in the late stages. So we have seen many causes of breathlessness, right? So for example, in COPD or in heart failure, we know the patient might have diagnosed with these diseases even before their 50s or 40s. Okay, sometimes even in their 30s, they might have diagnosed with these illness. So these are chronic illness and they may be struggling for a long time. So when a patient is having this chronic breathlessness and the etiology may be progressing, so when these patients are presenting to us, they might have undergone multiple visits. They may be on many medications and all. So not only the symptom management, we have to consider the patient as a whole. Okay. And so how they describe us that about their symptom, that is quality of dyspnea. We have seen the quality of pain. You might have learned about quality of pain in pain management classes. So like that way, here also there are different different ways the patient describes the breathlessness. The first, air hunger or unsatisfied inspiration, or work or effort or tightness. Next. First, air hunger. Air hunger means the patient may be describing to you that I cannot get enough air, doctor, or I am starving for air, or this breath that I am taking is not satisfying me. Okay, so the patient may be taking the breath, but only if we ask then only they may be sitting quietly, or they may not be lying down, they may be sitting up. So okay, they may be presenting to us in OPDs and all. So by seeing them, we may not be able to understand, they may not be taking that work effort, or that may not be there in initial stages. So when we ask about the symptom, they may be telling all these things. Okay, next. And another thing is work or effort. So we all know, when you are listening to this class, or when I am talking, I am taking breath, right? So I don't want to put an extra effort to take a breath. But there are many patients, there are many who have to put an effort to take a single breath. So uh, they will be describing like it's an effort, or my breath requires more work. Okay, or it can be tightness, like uh, which indicates broncho. It can happen in bronchoconstriction and all. They may be feeling like something is tight, or something is heavy, or heavy on their chest, like that way they may be describing. Okay. And causes in detail we can see. Uh, I know most of you might know all these things before, the causes of breathlessness and all, because the breathlessness is one of the most common symptom that we manage in OPDs, casualties and all. So the primary causes, in case of in palliative care, it is mostly in primary or metastatic cancer. So in primary cancer, the pathology may be in the lungs. So there may be some alteration in normal airway and also the ventilation or perfusion, or even the airway passage even affected. Or metastatic cancer also, okay, there may be edema also associated with this lesion, and depending upon the site of the lesion also, it will vary, the intensity of breathlessness and all, it will vary. And lymphatic infiltration by the tumor, we know the spread of tumor, it can spread through lymphatic route also. So there may be lymph node enlargement, there it may compress on the airway, or there may be edema, like that way. And malignant pleural effusion, we know it can be pleural effusion. We have seen, we can see pleural effusion in non-malignant cases also as well. So malignant and non-malignant pleural effusion. And tracheobronchial obstruction, any obstruction in the tracheobronchial tree, that can cause breathlessness. And treatment, like surgery, any surgery in the thoracic cavity, or radiation, chemotherapy. All these chemotherapy, radiation can cause lung fibrosis, and that can cause breathlessness. In ILD, interstitial lung disease, we have many patients with ILD with severe breathlessness. Okay, next. And ascites, it may not be a lung pathology. Okay, so the respiratory breathlessness is mostly the system associated is respiratory system, but the pathology may not be in purely associated with the respiratory system. It can be in the abdomen as well. So a enlarged liver mass, or hepatomegaly, or ascites, all these can cause breathlessness. You might know the reason for that, right? Why? Why? Can anyone explain? I can see many names. Many doctors are here. So, and yes, everyone may know. So, someone please. Am I audible? I hope everyone can hear me.
Yes, ma'am.
Yes. So, why? It's very simple. topic, and you may know the ascites and abdominal mass can cause breathlessness. Even a mass in the uterus or cervical cancers with a huge abdominal distension, they may be presenting with this ascites and all, which is very common in liver, HCC, hepatocellular carcinoma, CA uterus, uh, and all. And in those cases, what will happen is it will be lifting the diaphragm upwards, right? So when we are taking the breath, there is inspiration and expiration. In during the inspiration phase, the lungs will what lung will be inflated and it will uh, touch on the diaphragm. But when there is an upward pressure, it will cause breathlessness for the patient. So there will not be enough space in the thoracic cavity for the lung to inflate. So that's the reason. And cachexia. Cachexia is mostly associated with cancers. You know, there will be weakness of the muscles because of the loss of muscle mass and all. And cancer microemboli in the lung and pleural effusion. Again, we have already seen this. And causes, it can be cardiac causes as well. Cardiac failure, in congestive cardiac failure or in left ventricular failure and all, and pulmonary edema when a patient having pulmonary edema, pulmonary artery hypertension, or sometimes a patient with initial presentation may be even breathlessness. So in myocardial infarction, then arrhythmia, angina, all these disease can present as breathlessness. The patient may be presenting to you with pain and breathlessness or heaviness in the chest and all. So the pathology may not be in the lung or may not be completely associated with the respiratory system. And in pulmonary, it can be due to infection, PD, pneumothorax, pleural effusion, pulmonary embolism, all these things. Okay, next. So, what are the psychological causes associated with breathlessness? It causes an anxiety and it can cause panic attacks as well as depression. Okay, anxiety in the sense, yeah, next. Breathlessness is a common trigger for panic and it is a vicious cycle. Okay. Why? Because uh, when a patient is breathless, okay, they may be, for example, a patient with COPD, the patient may be breathless, they may have chronic breathlessness, but eventually their intensity of breathlessness may increase. And in their late stages, okay, in their late stages, they may have a fear in their mind, oh, how it will be in the future, or how my life will be at the end of life, or how can I go to work if my condition is like this now. So when a patient is breathless, and you should understand that they cannot even do their day-to-day activities, okay, their all their activities will be compromised. Okay. Uh, Apart from the symptom, you may have to treat the patient as a whole. So we may not be asking them what are the things that you are compromising because of the symptom like breathlessness. They may not be even able to uh, uh, look after their children. They may not be able to present well in their workspace, or may not be able to cope up with the stress, work stress, and all, or may not be even able to lie down and sleep well. So, totally, they may be affected. So, when when they are having these symptoms and all, they may be quite anxious how they will be in future or in the end of life itself. When a symptom is being present when there is breathlessness, they may be on already on many medicines, but they may not get enough response with bronchodilators or steroids and all, and inhalers and all. So when it is being non-responding and all, and when they are starving for the air, or when they have to put so much effort to take a breath, or like that way, they may be very anxious. It's quite obvious, right? So it is one of the symptom that is being associated with what anxiety. And I can tell, I will tell. And they will have a fear of dying, and also it's a vicious cycle. When there is dyspnea, that itself can cause a fear of dying, and that itself increase the anxiety, and this anxiety factor can also cause dyspnea. So we know, when we do not have even any single pathology associated with any cardiac or pulmonary or any other, even if we do not have any sorts of illness, when we are anxious, we may feel some breathlessness, right? So when the patient have already this pathology inside them, when they are anxious, it will be more troublesome for the patient, as well as the family members, as well as the uh, professionals, medical professionals, to treat them. So we may have to treat them. We may have to sit with them. We may have to. First thing we have to do is we have to understand. Okay, we have to understand they are going through all these sufferings, and uh, okay, only if we understand their situation, we can treat them properly. Okay, next. And we know, before any symptom management, we have to take the detailed history and physical examination. And in history taking, as all of you know, we have to ask when did it begin, and what's the duration, and how frequently does it occur, and palliative and propagating factors. That means what makes it better or what makes it worse. For example, even we know grading of breathlessness, we have already studied all these things before. Even sometimes the patient may be having breathlessness even in rest. Sometimes some of the patient have breathlessness or walking on a level ground. Sometimes the breathlessness may be present when they are climbing the stairs. In initial stages, they may be when they are doing external exercise and all, or uh, any activities which requires more effort or something, only they may be having breathlessness. But this grading, the stages goes higher, right, when they are nearing their end of life. So you have to ask them what makes it worse. Sometimes lying down on supine position, the patient may be breathless, or even drinking one full glass of water can make them breathless, or they may not be even able to take a full meal completely in one sitting, or they may not be able to go to work continuously. Okay, their work may need some effort, walking or like that way. So, all these things you have to consider. Then only we can make their life better. We can improve the quality of life only if we know what are the things that is being affected by this symptom in their day-to-day life. So these things you have to ask. Even in the pain, you have to ask these things. Sometimes lying down in one sideline position, maybe on right side or left side. We know for making a diagnosis, even it will help. And quality of breathlessness, that we have already seen how they are describing this breathlessness, and related symptoms. Any other symptom related, any other signs of infection, or any other signs like symptoms like cough, or whether it is due to their anxiety. Okay, so sometimes the patient may be presenting to you with breathlessness, but there may not be any what a serious problem that time, but they may be anxious, they may be worried for a chemo which is being planned for the next week, or surgery. They may be planned for their may plan for any surgery or radiation or any investigations like CT scan or biopsy or like that way. So that anxiety factor maybe the reason for their breathlessness. So all these things, or sometimes the patient, uh, children may be studying and they may not be studying well or doing well, or or the patient cannot even look after the family members, or all these things can cause anxiety factor in them, and we have to look into that. Okay. And isolation or anything, or severity, uh, you know, this from scale of 0 to 10, that is to have a better idea on the intensity. Then treatment, any treatment taken for it, uh, for breathlessness, whether they are currently on any medications. Okay, next. And physical examination. We know physical examination starts with vitals. We have to see the temperature, pulse, BP, respiration, everything. Okay. Then we know respiratory rate we used to see. Next, saturation and pulse oximeter. Yes, when a patient is breathless, the first thing that comes into our mind is the saturation, right? So we know in our OPDs and all, when a patient is severe breathless, before even checking the BP, the first thing we will be doing is knowing their saturation, checking their saturation. Or if it is below 90 and all, then okay, then we will put them on monitor and we will do continuous monitoring with beep sounds, everything. That's a usual practice we used to see. Next. And anyway, the vitals are important, then only we will get an idea about the patient. So we have to see. Uh, then general physical examination, the cyanosis. So this, you may know what is cyanosis, that is central as well as peripheral cyanosis. Cyanosis itself is a bluish discoloration uh, in the mucous membrane, and it can be in the tongue or oral mucous membrane in central cyanosis. Next. And physical examination, inspection, palpation, percussion, auscultation. First, inspection. Inspection, you know, from the way they are entering the OPDs, or they may be, they may not be able to walk, they may be coming in a wheelchair, or they may not be even able to lie down in complete supine position. So all these things from inspection itself, we can identify what are their symptoms and how severe it is. And position of the patient, yes, accessory active accessory muscles. We know there may be what movements of accessory muscles. The nasal flaring may be there, mouth breathing may be there. They may not be able to take uh, breath through their nose, or that may not be satisfying them, so they may be depending on mouth breathing. And palpation, all these things we have to check. In palpation, we used to do percussion and all. All this will help in making a diagnosis and the reason for breathlessness, the percussion and auscultation. And all in auscultation, we know we can identify whether there is any difference in air entry in all the lung fields, whether it is same, or whether there is any mass, whether there is any bees or secretions, or all these things we can identify in palpation, percussion, auscultation. Then pleural effusion and all also we can get an idea from uh, the physical examination. Accessory muscle wasting may be there, nasal flaring, normal nostrils and flat nostrils. and management. After making a complete idea about the patient's symptoms like breathlessness or any other symptom, we will take the detailed history, then examination of vitals and physical examination. Then we will get an idea what's going on with the patient. So after that, we can move on to the management, right? So we know the management, we starts with investigations. So, when a patient is presenting to you in a palliative care setup, so is it necessary to do an investigation for all the patient? I want at least some of you to come up with answers. I'm just asking yes or no questions.
No, ma'am.
Yes, why? Uh,
मैम बिकॉज जो जैसे क्रॉनिक वाले हैं बहुत टाइम से उस पे चले आ रहे हैं ऐसे ही है उनको तो उनके कुछ तो ऑलरेडी वो मतलब उनकी डिजीज एडवांस हो चुकी है उनका सब हो चुके होते हैं पहले ही जितने भी इन्वेस्टिगेशन होते हैं
yeah,
और वो सेटल्ड है मतलब उसी ब्रेथलेसनेस के साथ काफी टाइम से रह रहे हैं तो
yeah,
उस केस में हमें जरूरत नहीं है
yeah. Thank you, doctor. Yes, they may already have a diagnosis, right? So they may not be coming to you for the first time. Most of the causes are chronic cases, chronic causes, right? Even the cancer, or even if it is cancer or any others like COPD, heart diseases, or all these are chronic causes. So they may have already a diagnosis, proper diagnosis. So you will have an idea of with physical examination and all. Okay, it is not like you should not do any investigation for a patient to when a patient is coming to you in palliative care setup, but only if it is going to help the patient or only if it is going to alter the line of management, then only we should advise them investigations. There are many things behind this. First thing, uh, some of the patient may not be able to afford all the investigations, okay, that you are prescribing them. Why? Because they may be undergoing this process multiple times in their lifetime. So every time asking the patient to go for an investigation, it will be a burden for them. And second thing is it will add what uh, suffering to the patient as well as the family members. So they may not be able to walk, and they have to shift the patient. Sometimes there may not be adequate number of caregivers to support the patient. So the even an old age one may be accompanying the patient. So in order to shift the patient and all, it's very distressing for them also. They may be in our wards and all. We used to see the bystanders itself may be having some sorts of illness like back pain or some sorts of things. So when we are when we are starting the management, what is our primary aim? Sorry, our primary aim is to improve the quality of the patient as well as the family members. So we should not do anything that will add their suffering. Okay, so all these things you have to keep in your mind. And yes, but in some cases it may be much necessary, so you may have to explain to the patient as well as caregivers, uh, this is the thing and we are suspecting this one, so we don't have any idea whether it is due to that or not. So maybe for before pleural tapping and all, we may need to send them for X-ray or USG guided what pleural tapping may be needed. So in those cases, we may have to do the investigation, but it ultimately will improve the patient condition and it will reduce the suffering, right? So in those cases, you should not withhold them from investigations also. So only if it is necessary you have to, and you can go through the previous investigations, right? If it is being done within some weeks or so, then you may not be able to repeat it. So you have to keep that in mind. And X-ray, it will give a first initial idea about a lung pathology and or cardiac also as well. Then hemoglobin also it's very important. Anemia can also can present with breathlessness. In anemia, when a patient is severe anemic, that itself can cause tachycardia, that itself can cause pulmonary edema, and so or even heart failure it can cause. So uh, we have to see all these things. In USG, it's for differentiating the pleural effusion from solid tumor. So the patient may have a history of solid tumor, but during physical examination you might have a doubt that it may be due to pleural effusion. So in those cases, to rule out and to give a better treatment, we may have to send them for investigation. And CT scan is there, ABG analysis is there, and pulmonary function, lung function test, all these things are there. Yes, if it is necessary, you can send them, but unnecessarily, never send a patient for any investigation. And okay, consider a scenario. A patient named X came to a OP with severe breathlessness, and he's having advanced disease and no treatment which is possible, and he's accompanied by his family who is very anxious about his condition. Okay, so what will you do, and what can happen in your in a regular setting? Okay, suppose this patient comes to you in your setting, so what will you do normally? Okay, please. So only if someone answer, we will move on to the next slide.
मैम जैसे कि हमें वो पहले से ही डायग्नोज है कि भाई वो एडवांस डिजीज में है, नॉट ट्रीटेबल कंडीशन में है, तो हम इन्वेस्टिगेशन के लिए तो नहीं जाएंगे। हम जैसे वो हमारे पास आएगा तो हम उसको किस वजह से हो रहा है पहले रूल आउट करने की कोशिश करेंगे कि इसको क्यों हो रही है इतनी ब्रेथलेसनेस, और पल्स ऑक्सीमीटर से उसका SpO2 देखेंगे, और उसके बाद जो भी पॉसिबल हम उसको वहाँ रिलीव के लिए जो हम दे सकते हैं वो हम उसको हेल्प करेंगे, देखेंगे कि इसको किस वजह से हो रही है, किस पोजीशन में होती है, कैसे होती है, कब क्या हो रही है, सारी हिस्ट्री लेके मतलब उसको मैनेजमेंट उसी हिसाब से कि भाई हम इसको कितना हेल्प कर सकते हैं कि ताकि ये आराम से थोड़ा कंफर्टेबल अपना जितना भी टाइम है उसको निकाल सके, तो उसमें उसकी हेल्प करेंगे।
Yeah,
सिर्फ
these are
बेसिकली सिम्टोमेटिक ही देंगे कि किस वजह से हो रहा है, तो उसको इतना अगर बहुत ज्यादा सीवियर है कि 90 से भी नीचे जा रहा है और हमारे पास O2 अवेलेबल है तो फिर हम उसको O2 देंगे।
yes. Thank you, doctor. Yes, these are the things that we do in our day-to-day practice normally. We will be checking the vitals if it is below 90 or 80 or something, then we will put the on oxygen mask, and we will be sometimes if ICU, if the patient, if our setting have ICU, what we will do? We will definitely transfer the patient to ICU. That is what happen in normal hospitals, right? So uh, in regular setting, these are the things. Or if it is below 90, or even if it is below 94, 92, 90, like that, also put them on continuous monitoring, observation, like that way, right? So, okay. So here you are getting exposed to palliative care. Yes, some of them have answered in the chat that oxygen we have to manage, nebulizer, BiPAP can use, semi-fowler position, oxygen symptomatic treatment, then first we have to stabilize the patient. Yes, all these things are correct. But yeah, we have to, we must know that it varies symptomatically and individually. And not all the patients who have what saturation less than 95 need oxygen. In COPD and all, the patient may have a saturation fall normally, even after giving this oxygen and all for continuous oxygen may not help them for improving the saturation. So you have to keep this in mind. Okay, and all the sometimes saturation may be 100. So in those cases, you may not be able to put them on oxygen. The patient may be breathless, but the saturation may be 100. So all the cause of breathlessness are not hypoxia. Okay, or ventilation perfusion only if it is being affected, or only when there is a decrease in oxygen level, we have to what give this oxygen. Or sometimes in some stages this anemia and all, okay, yes, while correcting all these things during breathlessness it may help, but in all cases the oxygen may not be needed. Okay, next. Okay, when a patient is being coming to us with all these factors, all these symptoms, and the patient and the family may be anxious and everything. So you have to sit with them, or with the family as well as the patient. You have to be very calm. Okay, so you have to communicate what is going on with the patient. Okay, we know there are many situations. It's not same for all cases. For example, in COPD cases, when a or pulmonary edema, when a patient is being coming to you, yes, you have to act uh, quickly. You have to give the oxygen. You have to give diuretics. You may have to give steroids and all. Yes, sorry, you can give, and the patient may improve. Sometimes the patient may not improve. So uh, better to communicate what you are going to do or what the patient is being undergoing. Okay, if you get an idea, then you have to communicate it to the patient as well as the family in the initial phase itself. Okay, and then we have to address their concerns. Okay, then explain about his condition. It's different from a regular setting or regular management protocol. Okay, in palliative care, first thing we have to ask them whether they are aware about palliative care, or whether they uh, want any curative treatment, or whether they want only symptomatic management, supportive care. All these things you have to be very careful. Okay, sometimes they may not be even know what is palliative care. So, in palliative care, we know it starts with the diagnosis, and as the disease advances, uh, the role of palliative care increases. Right. So, in the initial stages, there may be a role for curative treatments. Right. So, for example, when there is an anemia or something, there may be a breathlessness, but if it is in the initial stages of this cancer, it can cause anemia, can cause anemia. So, the anemia correction can help the patient. Yes, definitely it can help the patient, or the patient can survive for some few months more. So, we may not deny that, or we may not restrict them from not doing the blood transfusion or correction, or edema management, or any other. So in the initial phases, their curatory, it should be accompanied with the curatory options, yes, of course, but in advanced cases, or in end of life, or in late stages of a chronic illness, the situation is different. So in those cases, there may be having chronic breathlessness and chronic symptoms which is not responding to the normal management. So when a patient is been presenting to you with all these things, you should understand, okay, sometimes the curative options or normal line of management may not help them. So the role of palliative care will be more in those cases. Okay. So what we have to do is we have to explain them. We have to uh, sit with the family members and the patient if possible. We have to tell them what is happening, and sometimes the etiology or the pathology may not be responding to the treatment of chemotherapy or radiation. Okay, so in advanced lung cancers, the patient may have breathlessness, and that is definitely going to worsen in future. So in end of life or in advanced stages with poor prognosis, you must sit with them and you have to tell them this is what happening with you, this is what we are expecting, this is what we can do. You have to make a treatment plan. Okay, unnecessarily sending them for again for curative options or that may not help. Okay, they that will only add distress and what burden to the patient and the family members. And they may be um, okay, they may be even asking you even after taking all these things. Some patients will ask, I have no response, why? After even after taking all these medications and all, I'm not getting okay enough response. Or they may be telling you, the doctor have already told there will be improvement. Okay, we not should not give any false hope also. So all this you might have learned from communication. But when a patient is breathless, when a patient is in advanced disease, advanced stage of a disease, or in end of life, all these things, this breathlessness is common. So this you should definitely keep in your mind. Sending the patient in advanced stages for a curative option or trying the usual line of management may not help the patient. Okay, so we have to sit with the family members and make a treatment plan, the likely benefits of the treatment, as well as what we are expecting in the future, everything, the prognosis, you have to discuss with them. And okay, next. Yeah, that scenario, um, we may shift the patient to ICU in normal protocols. In multi-specialty hospitals, when a patient is being presenting with the severe breathlessness with desaturation and all, definitely they will shift the patient to ICU. They may have to be away from their family members. Sometimes only days may be left. Okay, so putting them in a ICU, and if put in an ICU and we are expecting some good response, that's completely okay. But if it is not, then uh, it's not a good thing. And in advanced stages and all the invasive and non-invasive methods we can follow, right? So you have to, if the patient is conscious and if the patient can make a decision, then you have to ask them. Most of the patient may not be what willing to put a oxygen mask or intubation and all, they may not be preferring. Okay, next. So you have to ask the patient also, what they want in their end of life, or what they want in these stages. Or if you have a better idea about the patient and their prognosis, even before coming, before these symptoms, you can sit with the patient and the family and you can make a plan of treatment if it can happen in future. So what do you prefer, how you want to be treated if it happens like that way, you can make a plan also before also. Okay, so yes, character correctables that we should not uh, miss this one. Character correctables, if we can improve the quality of life and if it can prolong the life of a patient for even day or 1 hour without harming them or without uh, adding any distress to them, it is needed. So correcting the correctable is very important. So, and non-pharmacological management and pharmacological management. Correctables, we know when it is infections, you have to treat the infection with antibiotics and pleural effusion. You can do thoracentesis, ascites tapping, you can do diuretics, you can add, and anemia correction you may have to do in heart failure, diuretics, AC inhibitors, all these things in the initial stages you must do. And if it is necessary to take a what consultation with this consultation with pulmonology or pulmonologist or cardiologist or parallelly you can send them for consultation as well in the initial stages. Next. And non-pharmacological management, first thing is, yes, we have seen anxiety. It's a vicious cycle. So we have to calm the patient. How you can calm the patient? One of the most effective thing is you have to understand. Okay, you just have to admit that uh, they have these symptoms and they have this distress, they are undergoing all these sufferings. Yes, is I understand, or I understand you are suffering, or I am with you. All these words will make a huge difference in their life. Okay, the symptom may be there, but these words can help the patient. They may be getting someone who can understand them. Okay, so which is very important. So it is not like, okay, you have the symptom, just writing this medicine and sending them. Like we doctors or in medical professionals, we used to we may not get enough time to see a patient and to talk with them in normal casualties or OPDs, and also we should make some time for the patient and the family. We should sit with them. We should make them calm. Okay, we are with you. Oh, all these things will help the patient. Okay, so loosening the patient clothes. If it is tight clothes, then you can loosen the clothes, and using table fan to maintain air circulation. Yes, you can use that. Uh, then table fan, not only table fan, even a small cooler or cooling fan which is being available in the market, you might have seen before, or handheld fan can help the breathless patient, so that can be given in their bedside, so the cool air, that circulation, that they will feel better. And loosening, okay, that we have seen. And using table fan to maintain air circulation, or handheld fan, or keeping the room windows open, increasing perception of space. Yes, if possible, better to make a bed for them in well ventilated rooms, and comfortable position, Fowler's position or prop position, whichever patient is comfortable, or sideline position they may be preferring, or okay, you can ask the patient. And modified breathing technique, diaphragmatic breathing, uh, pursed lip breathing. So you can even pranayama, that's yoga, but still the deep breathing exercise will help the patient. That will reduce the respiratory rate, as well as the in the initial stages. If you are advising them, they will be able to what cope up in their late stages. Okay, and next. Then coming to pharmacological management, we know bronchodilators is a primary medication that we prepare in a patient with breathlessness. Uh, okay, short acting as well as long acting bronchodilators are available with or without oxygen supplementation. if the oxygen saturation is for there is desaturation or oxygen saturation for, definitely we can put them on oxygen. But when we are putting them patient on oxygen, we must discuss it with the family members, especially in the advanced stages. Okay, in early stages of a diagnosis, the scenario will be very different. The patient will be well responding to the oxygen and this bronchodilators and all. But in the advanced stages, they may not be responding well. Even with oxygen saturation, sorry, oxygen supplementation, there may be desaturation. In BiPAP, how many of you have seen the patient falling or desaturation happening when a patient is on BiPAP? Did anyone see such cases? So the doctors may advise intubation or like that way. So will that be helpful for
Yes,
them in?
ma'am.
Yes, yes. We used to see the cases in BiPAP. Even if we put the patient on BiPAP for some days, yes, they may survive for few days. But after that, with that BiPAP itself, there may be oxygen desaturation, oxygen fall, and again they may have to intubate the patient and put them on ventilator or something. So all these stages you can make a plan by sitting with the patient and the family member. Sometimes the patient may not be able to take a decision in late stages. So in palliative care, what we do is, if the patient is coming to you with CL lung, initially may be presenting with pain. Okay, there may not be any breathlessness. So we should tell them there is a chance for these things, not to make them anxious, but to make them aware about all these things, and they may will be able to manage in the home itself. So they may not get panic, or okay, like that way you can make a plan. And oh yes, and next, corticosteroids. Yes, we know it's most commonly used. Uh, that will decrease it. Definitely, these corticosteroids have a very important role that will decrease the peritumoral edema. And we know when there is an edema, it will compress the nearby vascular structures and nerves and everything, or nearby structures, that can cause breathlessness. Even a small decrease or small increase in the diameter of the alveoli by reducing the edema can cause or can bring a great relief for the patient. And pharmacological management continues. Opioids. Yes. What's the importance of today's class? Till this, all of you know what happens, what we can give. We can give inhalers, we can give steroids, we can give diuretics, we can give the bronchodilators, oxygens, everything we know already. But the morphine, the use of opioids, morphine, in for, breathlessness, for managing breathlessness, it may be a new idea or a new knowledge for all of you. Okay, so we may have used morphine for pain management, but there is a role for morphine in breathlessness management as well. That is in intractable dyspnea, which means the dyspnea which is being not responding to any other treatment. Okay, that is found to be safe as well as effective, but we may not start the morphine in a regular dose which we use for pain management. In a very low dose, we start. Okay, what does morphine do in pain management? Did you get the class on pain management?
Yes, ma'am.
Yeah. Okay. What's the site of action on morphine? Which receptor? It acts on mu receptors. Okay. So it acts on mu receptors on the respiratory center, and what will it do is it slows down the respiratory rate. Yes, we know when we hear this slows down the respiratory rate, we all fear about respiratory depression. Even for pain management, there are many phobias associated with this morphine use. So we may not get anxious or we may not get panic for starting morphine in this very lower doses. And when the patient is having this breathlessness, we may not feel any source of hesitation for starting this morphine. In very low dose, we can start. That means 2.5 milligram. 2.5 milligrams 6th hourly you can start for a patient with breathlessness, which is intractable. For a patient with intractable dyspnea, it will help. Okay, there may be an effort or extra work they may be putting to take even a single breath. So when we are starting this morphine, what this morphine does is it will reduce the excessive respiratory drive, okay, or reduce inappropriate respiratory drive, and breathing is made more efficient, and sensation of breathlessness is also reduced, and it also slows down or respiratory rate also it will comes down, the patient will become calm. Okay, so in an opioid naive patient, you can start with 2.5 milligrams 6th hourly. Initially, you can start it. Is there morphine available in your setting?
No, ma'am.
No. Okay. So, for pain management or and all, how you are managing now? If there is a need for morphine.
मैम अभी करंटली पैलेटिव केयर अभी कर नहीं रहे हैं, सिर्फ अभी कोर्स जो ये स्टार्ट करा है इसके बाद में भी हमारे जो सेटिंग्स है वहाँ पे इम्प्लीमेंट होगा ये।
Okay, okay, good. So you have to keep this in mind in future. If when it is being available in your setting, you should not hesitate to start this morphine for a breathless patient, but initially, not in the initial stages. Okay, so if it is not responding to the normal line of management like bronchodilators, steroids, inhalers, diuretics, or after being correcting all the correctables and doing the possible things, and when the patient is being in advanced stages, advanced disease, or an end of life, or in severe COPD or ILD, interstitial lung disease, all these cases, or chronic breathlessness cases, heart disease. Okay, in those cases, we know. Okay, the morphine will definitely help. In those cases, you should not hesitate to start the morphine, even after completing the course. If you are met with such a case, you may. I know before coming to pallium or before starting practicing palliative care, I was also uh, I also had fear for giving this morphine for even pain management. So if you have any sorts of anxiety or hesitation, you can contact us. So we will be here for you to guide you. So even after this course, so if you need any help, you can contact us. We will be getting the contact details from our uh, what administrative staff, so you can get contact details from them as well. So anyway, the main aim of this class is you should have an idea, all of you should have an idea that the morphine will help in breathlessness management. How means it acts on mu receptors, it acts on the respiratory center, it will reduce the excessive respiratory drive, and it will reduce the sensation of breathlessness, and they will be patient will become calm, and patient will be able to rest and take breath peacefully, and the dose is very less. That also you have to keep in mind. It is not the usual dose that we start for pain management. It is a lower doses, which is 2.5 milligrams 6th hourly. Okay, then we have to monitor for the opioid toxicity, everything you have to do, whether it is being started for pain management or breathlessness, you have to be aware about all those things. And nausea, the regular protocols that we follow while starting this morphine, that you have to follow. That means the morphine induced nausea, we have to give an antiemetic prior to that, that you have to follow here also. And default laxatives also you have to use. And benzodiazepines, yes, to relieve anxiety, you can start with the benzodiazepine, and which is not the first line. So, if the patient is okay, for example, I have seen one patient, and the patient was very young. So, the patient was having renal cell carcinoma with lung mets, and there was ascites and all. After doing all the correctables and all, still the patient was having breathlessness and sleeplessness. And when we take the history on during the rounds and all, we came to know that it is due to his anxiety. So he's very anxious what will happen to his family if something happens to him. So, and what will happen to him in future, whether it will improve. Condition, the doctor gave a false hope that from the treating center that the condition will improve, but the physical symptoms are increasing day by day. All these things was making him anxious. So that case we have to start on what benzodiazepine. So we can, if it is in the night time, if the sleep is being affected, then we can give the short acting midazolam. And if it is very severe, or if it is needed, we can start lorazepam long acting as well. Next, oxygen trial, as we have already discussed, we can put them on oxygen. We can use better to avoid this oxygen mask and all. If there is nasal prongs, you can use that nasal cannula. Why? Because the face mask itself can cause a sense of suffocation, and they may be drying up the tract, as well as the, it's a barrier for communication. The patient may already have a feeble voice, and putting again them on a face mask will cause what? A patient may have to put extra effort even to speak. And blood oxygen equilibrium, that will be in reaching in 7 minutes. And so what you have to give is, you can give this oxygen trial for first 10 minutes, or oh, okay, I will suggest you can give it for 30 minutes or 20 minutes and see whether there is a increase or improvement in saturation. So if there is no improvement, even after giving the full-fledged oxygen in 10 liters or 6 liters or 8 liters, you may be giving this oxygen. So even with oxygen, the patient is not improving. In advanced stages, you may have to explain to the family this is what happens when this oxygen may not be helping them, because in the end of life or in the late stages, there will be uh, decrease in blood flow, there will be decrease in perfusion ratios, and it the cells may not be taking up this oxygen. Okay, so this and in some cases, the hypoxia may not be what there may not be any saturation, desaturation fall, but patient may be breathless. In those cases, you should not give this oxygen. In COPD cases and all, you can discuss it with a pulmonologist even. Why? Because when you are giving this oxygen, it will itself reduce the, it will put an extra effort for the patient. Okay, so their normal respiratory drive will decrease if you are giving this. So it will be adding burden to them. So that all you have to keep in mind. So prior explanation to the family is required to avoid misunderstanding when oxygen therapy is discontinued. That is very important. Okay, next. Okay, these are up to this time we have seen breathlessness management. So the communication is very important. When we are discontinuing, if we have a plan to discontinue this oxygen, you should definitely discuss it with the family members. Otherwise, they will come and ask you, the patient is breathless, then why the doctor is not giving, the setting is not even giving this enough oxygen for the patient. They may be taking the patient away from you to another hospital. So you should tell them this is what happening. This may not be helping them, like that way. And next symptom is cough. This is also one of the most common respiratory symptom. This prevalence is more common in cancer and COPDs and infections also. We used to see this cough. And patient also experience a psychological impact, and it will cause a social embarrassment and isolation. Why? Because, for example, you are going for a function and you have this cough which is not being responding to anything. So what will happen is you will be feeling some embarrassment. You may be coughing throughout, so you may not be able to attend, or you may not be able to talk with the friends or family members, like that way. So in cancers and all, in CA lung, CA supraglottis, or in all those cases, when there is any when there is any interruption in the airway passage and all, irritation itself can cause this cough. So there may be foul smelling discharge or a foul smelling sputum, or all these things are there. So all this will cause some isolation also in the patient. So all these things you have to keep in mind. Next, causes of cough in palliative care. The first thing, tumor. Yes, we have seen tumor. It is more likely to cause cough with involvement of airways than the lung parenchyma. There will be irritation, right? And cancer involvement of pleura, pericardium, mediastinum, pulmonary lymphatics, and blood vessels can also cause cough. And aspiration, we know patient with cough on feeding or at night, yes, aspiration pneumonia, all this can cause cough. And hypersecretion of the mucus is also associated with cough. Next, what are the complications? Can cause physical complications, including chest wall pain. Yes, continuous cough can cause chest wall pain and fracture of ribs, urinary incontinence, sweating, exhaustion, disturbance of sleep. All uh, these things can be caused by cough. Okay, next. So assessment of cough, it is very similar to all other symptoms. You have to go through the history, then physical examination. Next. And coming to the management, we will be the if it is a cancer related thing, then you can definitely send them for a treatment of cancer. It can be radiotherapy, chemotherapy, treatment, maybe palliative cough due to tumors. That means chemotherapy can help if it reduce the size of the mass, or uh, in some cases in early stages it will help, and radiotherapy can help. And what steroids is, we have seen the it will reduce the peritumoral edema. The steroids will definitely help. When this edema decreases, there will be more spaces in the alveoli, and there will be more perfusion, and it will help in the what management of cough as well. So airway obstruction will reduce, irritation will reduce, and secretions will reduce. All this can cause an improvement. And correcting the correctables, which is very needed, and underlying infections, if any, then also you have to treat the infections. Suppressing cough and disease, that means we know when a patient is being presenting to you with a dry cough or a wet cough, we used to prescribe many medications, which is centrally acting and peripherally acting. Most centrally acting and it disease are opioid receptors in central nervous system. And next, for example, morphine. Uh, it may be many of you may have been wondering using morphine for cough management, but personally, I have seen two cases. It's very rare for using this morphine for cough management. So, in the past 1 year, I have seen two patients with intractable cough and breathlessness. They are on 2.5 milligram BD dose of morphine and they have very good response. Currently, they are not taking any other treatment, but for their chronic cough, the diagnosis is ILD. Uh, there was, I'm not sure the diagnosis is ILD. For ILD, morphine was being started for breathlessness. For another two patients having this chronic cough also, we have started this morphine in very low dose, that is 2.5 milligram BD dose. We have started, and there is very good response. Okay, she can even uh, do the day-to-day activities, and for long term, for more than 6 months, she is on this morphine, and she is giving good relief. So you should not hesitate to start this morphine for cough, which is not responding to the other treatments. And we know this codeine, dextromethorphan, and all these are also acting centrally, which is being a normal content in our normal cough syrups and also. You should not hesitate to start this morphine if it is needed. Next. And other medications we know, mucolytics like amproxol, bromhexine, and emulsions like soothing substance like glycerol, all these also will help. It is not like you should escape or you should skip the initial phase of management and jump into the morphine to control the breathlessness and cough with morphine. It is not like that. You can start with initial things, initial line of management, and sometimes mostly the patient may be presenting to you in the late stages. They may have tried all the medications like bronchodilators, steroids, everything. So when the patient is coming to you, if you are giving them again all those things, they may not be, it may not be helping them. So uh, what we can do in the end of life or advanced stages or in chronic cases in the late stages is there may be a limitation for their even their life expectancy. So those days you can make better, or you can make a quality improvement in their day-to-day life. So there is no harm in starting this morphine in such patients. Okay, so we are not expecting the respiratory depression in such cases when the patient is having intractable breathlessness or a cough or pain. So even if we do not start, they may not be even able to enjoy their life. Okay, so if there is any medicine which is being available uh, that can make any improvement in their quality of life, then we should not what withhold that. Okay, so we should not hesitate. We can so and once again I would like to remind you that even after completing the course, if any patient is coming to you with all these symptoms, or if you have any hesitation to start any of the medications like morphine, or sometimes in future you may be coming across palliative sedation or treatment of delirium. Okay, anything you can contact us also. Uh, we all will be happy to help you if we can. So, with this, we are ending up this session. There are other symptoms also like hemoptysis and all. So, you will be getting that in other sessions and all. Okay, so the most common symptoms we discussed today in this session. So if you have any doubt, you can ask. So
मैम जैसे आपने बताया था वर्ड्स का कि हम कफ और रेस्पिरेटरी उसके लिए हम यूज कर सकते हैं, तो जैसे कुछ पेशेंट होते हैं जो ऑलरेडी पेन के लिए ओपोइड्स पे हैं ऑलरेडी, तो वहाँ कुछ और उनको हो रहा है इस तरह से नॉन रिस्पॉन्डिंग टू ट्रीटमेंट कफ हो रहा है जैसे, तो उनको कुछ डोज बढ़ाने का या कुछ होगा उससे, या फिर ऑलरेडी वो ले ही रहे हैं तो ऐसा कुछ नहीं है कि हम उसको डोज बढ़ा के दें ओपोइड की तो कोई रिलीफ होगा?
so what's the diagnosis?
मैम जैसे पैंक्रेटिक कैंसर के लिए कोई पेशेंट है और
Okay,
ऑलरेडी वो मॉर्फिन पे चल रहे हैं।
so currently uh, the patient is having pain, right?
पेन है हाँ, तो उनको मान लो कफ होती है और नॉन रिस्पॉन्डिंग टू ट्रीटमेंट है, तो क्या हम उनको फिर ओपोइड्स की डोज बढ़ाएंगे?
Currently, which dose? At,
मैम पेशेंट को है नहीं कफ, वो ऑलरेडी जैसे मान लो मॉर्फिन पे है, मैं जस्ट मेरे माइंड में आया है तो पूछ रही हूँ कि ऐसा कोई केस ऐसे हमारे सामने आता है, उनको
uh-huh.
नहीं है कफ पैंक्रेटिक कैंसर वाले को, पर जैसे उनको होती है तो क्या हम उनकी ओपोइड की डोज जो है उसको कुछ अल्टर करेंगे उसके
Yeah.
लिए, कफ के लिए?
Okay. Okay. If the patient is having this pain, if it, for example, in pancreatic cancers and all, the patient will be having severe pain. Okay. It may not be purely nociceptic pain. There may be a neuropathic component as well. So you have to identify the cause of or the quality of pain and the causes of pain. Sometimes the steroids may help in the initial stages by reducing the edema and all. And you can start morphine if according to the severity of the pain and the frequency of the pain. You can start morphine if it is continuous pain or if it is severe pain, then you can start with 5 milligram. If it is an opioid naive patient, you can start with 5 milligram fourth hourly. You can start. You know the metabolism of morphine, the peak T half and everything. If the patient is having some renal failure or a liver failure or something like that, you can start with sixth hourly dose. Okay, then after that, you can follow up the case. If the patient is not responding, definitely within 48 hours also you can increase the dose of morphine from 5 milligram uh, so that we cannot what just tell you like you have to increase from 5 to 10 or 5 to 7.5. It depends or it varies individually. Each case differs, so you have to take the history, you have to do proper assessment, review calls, you have to do how many hours the patient is getting relief with the morphine or the pain medications, adjuvants you can add. Okay, so if a patient having this pain, having presenting with cough, yes, in this pancreatic cases, we are not expecting them to have an intractable cough or cough which is not responding to the normal line. Maybe a cause, maybe infection or something like that. Or if it is a lung mets or something, definitely you can try with giving what bronchodilators, inhalers, and steroids initially you can start with. And if it is not responding, and if the patient is already on mostly there will be relief for this cough. But if there is increased secretion or something, you may have to add some antisecretives like anticholinergics you may have to give, glycopyrrolate you may have to give. It differs. So uh, if the patient is not responding to pain, you can definitely increase. Usually, we have seen that the patient will be responding to very low dose of morphine to the cough and breathlessness. They will be getting relief. not morphine alone. Okay, morphine alone can give relief. Definitely, it can give relief, but sometimes we may have to add some adjuvants like steroids and all. Also, sometimes this reducing secretions we may have to add anticholinergics or something like that. So this depends on the case. Definitely, if the patient is not responding to morphine in the starting dose, you can do the follow-up calls, and what you have to do is you have to ask them how many hours the patient having pain relief with the morphine in the current dose, whatever dose it is, maybe in the 10 milligram or 20 milligram, whatever dose. Before increasing the dose, you have to ask them whether they are taking the medicine on right time. Okay, they may not be taking, we may be prescribing the medicine 4th hourly, but patient may not be taking the medicine fearing oh, this morphine, and or they may be thinking in their mind that they have to take along with the chemo or other medicines, again these medicines. Like that way, you have to ensure drug compliance before increasing the dose. Otherwise, the patient may go to toxicity. So you have to first ensure the patient is having drug compliance, and if it is even after taking the medicine, if it is not responding, definitely you can increase the dose by a 60% increase. You can do in a initial days, and you can, what you should do is like other medications, you it is not like the usual practice. We have to do the follow up. There should be reliable caregiver. We should have the what contact details of the patient. We have to do the follow up in our setting. Used to follow up within 48 to 72 hours. If it can be practiced, it will be very helpful. And toxicity signs also you have to explain them, so that the family members or caregivers can also bring the patient to you if they're suspecting any toxicity. But
Thank
in
you, ma'am.
very low dose, we are not expecting any sorts of toxicity or respiratory depression. So you should not hesitate to start morphine for breathlessness and cough management in very low dose, 2.5 milligram 6th hourly. We can start for breathlessness management, and yeah.
So thank you, doctor. Thank you for the wonderful session, and see you all in the next session. If you have any doubts or anything, you can just message in the WhatsApp group itself. So thank you all. Thank you all for joining the
Thank you,
session.
ma'am.
Thank you all.